Welcome to the House of Health podcast. I'm Dr. Anita Raja here with another episode of House of Health podcast. Today we have invited Miss Salena Bains, who is an oncoplastic breast surgeon, and we're going to ask her a couple of questions. Welcome to the studio.
Thank you so much for having me.
Fantastic. So we'll crack on.
Absolutely.
The first question is, when it comes to breast cancer,
Yes.
what are the risk factors?
Well, we've got a couple of groups of risk factors, really. So we've got the modifiable risk factors, and these are the risk factors that we can do something about. Mm-hmm. So, for example, our weight. So we know that there's an increased risk of breast cancer if you've got a high BMI or you've got an increased amount of fat that you're carrying. We know that we could reduce 8% of the breast cancers by people having a healthy weight. So that's something we can do something about. Also, a preventative modifiable risk factor, if you like, is doing exercise. So we know this is a protective factor. So it's really important that we can look at improving that. Another thing is alcohol intake. So we know that if we increase our alcohol intake, that will increase our risk of breast cancer. The more you drink, the more the risk is of developing a breast cancer. So these are probably two of the main ones. So I'd say obesity and alcohol intake. There are some more preventative risk factors as well, such as breastfeeding. So that will help protect you from developing breast cancer. And we think that about 5% of people, 5% of breast cancers are reduced by patients having breastfed. There are other things that we can't do anything about. So we've got non-modifiable risk factors. So we can't do anything about this at all. You've got people who, for example, might not be able to breastfeed. So that's not something that they can modify. We know that the two main risk factors for breast cancer are being female and getting older. We can't do anything about that. The other non-modifiable risk factors might be gene mutation carriers. So people have BRCA gene mutation. That might be something that people have heard of. So that sort of thing, you can't really do anything about that. So the key thing is to try and modify the ones you can and just hope for the best and make sure you remain breast aware and keep an eye on things and pick things up early if possible.
And when it comes to people of colour, have you seen that there are sort of myths, cultural taboos around the understanding of breast cancer?
Yeah, absolutely. So what we find, even growing up, for example, I remember being told you can't wear a bra at night, that will give you breast cancer. You can't wear a black bra, that will give you breast cancer. These things, I mean, this is something I've heard growing up, not from just my parents, but my friends who are of colour who are told similar things. There's big cultural taboos with breast cancer. So I'm Sikh from the Punjabi community, and there are lots of taboos about talking about breast cancer. I spoke to a lady who developed breast cancer, and she was, I think, in her 40s or 50s, and she didn't want anyone to know because she said, no one will marry my daughters because I've got breast cancer. So these kind of things are heartbreaking, really. And when we don't talk about things, then things are hidden, things are not discussed, and that just makes things worse. So if somebody does then notice a lump, they might not seek attention because they're going to be scared, this is going to be cancer, I'm going to be shunned, no one's going to talk to me, no one's going to marry my daughter. So these are the kind of things we've really got to fight against, because the more we know within the community, the more awareness there is, the better we know people will do. The other thing that we hear is, cancer's contagious, which is absolute nonsense. We also hear that people don't want biopsies because they think that if you've got a lump in the breast, you have a biopsy, that's going to make it spread. And I've had patients very recently say this to me, and you have to try and fight against that, say, no, that's not the case. We see hundreds of patients a year, this is not an issue. But again, if it's culturally ingrained, it's very difficult to break that. Also, people think that all lumps are cancer. That's not the case at all. Most of what we see in our clinic are benign lumps. So again, if you're worried it's something, come and get seen. We'll be able to hopefully rule it out. But if it is cancer, then we can do something about it. Another thing is men don't get breast cancer. That's not true at all. Men do get breast cancer. So we know about 400 men a year within the UK develop breast cancer. It's a small proportion compared to the overall number. But as I say, about 1% of the breast cancer that we see are in men. So at our unit, we treat about 1,000 cancers, and I'd say we see about 10 men a year with breast cancer that are treated and do well. I'm just trying to think of what else we've got. Mammograms.
Yeah.
So people will say to us, mammograms cause cancer. Mammograms don't cause cancer. So there's radiation involved, absolutely, but there's radiation involved when people have chest x-rays or they have CT scans. And when we travel, people don't think about this. So say you get on a transatlantic flight, you're getting radiation. So if you travel across from here to America, that's the equivalent of the radiation for a chest X-ray. So if you do a couple of transatlantic flights, that's the same amount of radiation as having a mammogram. People don't not travel because of the radiation risk, so why not come and have mammograms done? So it's a really important thing to try and break apart some of these to make sure that people come for the screening and they come and seek attention, really. And with the screening programme, so that's a programme, women between the ages of 50 and 70 are invited for mammograms every 3 years. Of course, if there's problems in between, they should seek medical attention and they can be checked out. Now, what we know is that people from ethnic minorities are less likely to come for their screening mammograms. And again, this will come back to the cultural taboos. This will come back to, we don't talk about breast cancer. It will give you breast cancer if you have a mammogram. All of this, and it all feeds into it. And there's cultural barriers with regards to language. So we do have lots of literature that's in different languages, but we also appreciate that there's a literacy issue in that people may speak different languages, but they may not be able to read that different language. So it's important that we go into communities, we go to places of worship or community centres and try and spread that message to just make people aware. Because people are invited, but they'll just put the letter to the side and not come. And we know that people don't do well if they come later.
Yes, definitely. And also, I guess there's an element of shame around speaking about the breast in general.
Absolutely.
So nobody wants to talk about their breast. They don't want to talk about breast health. A mother will never tell their daughter what to look out for, which I think is your duty as a mother to tell your child what to look out for. Like we, in our culture, don't speak about puberty as much and periods and lumps and bumps and breast cancer and sex and so many other things. Absolutely. It's just one of those things that we don't want to appreciate, acknowledge, and we just feel that once we just put that letter aside, nothing will happen to us, we'll be guarded. Hopefully nothing bad will happen and we can just get on with life. Now, when you, do see people in your clinic with potential breast cancer, what are the symptoms? How do they present?
So the most common presentation we probably get in clinic is breast lumps. So patients may notice something or their partner may notice something and they come and see us. Other symptoms are skin changes. So patients can have redness or dimpling. We call it like an orange peel appearance. So you can it looks like there's lots of little dimples in the skin. There can be discharge from the nipple as well. A lot of these things can be very benign and normal, but they can be cancer. So say, for example, bloody discharge, that might be something that we'd be more concerned about compared to some, milky coloured discharge in someone who's breastfed in the past, for example. Breast pain is something that gets talked about quite a lot, but a key thing to say is breast cancer does not hurt. They've done studies where they've looked at thousands of women who presented to the breast clinic with breast pain, and there was no link between the pain and cancer. So the key thing about that is to make sure you try simple measures. If the pain doesn't improve over a few weeks, then of course go and see your doctor and they can refer you on if they feel that they need to. But pain in itself is not something to worry about. And I think that can cause a lot of anxiety in patients because patients normally associate pain with something bad. But breast pain, again, mothers don't tell their daughters that actually when you have your period, your breasts are going to hurt a little bit. They'll get a bit lumpy and then that should settle down. But that's something that I think it's important to get out there. The other way that patients might present to us in clinic is they may have had a scan for another reason. So they may have had a CT scan for, breathing problems. And then on the scan, they'll notice something in the breast and then they get referred into us. And then also through screening. So we will get patients coming to us through the screening service as well.
And Salena, if we speak about sort of breast cancer numbers, patients that are suffering from them, what the survival rates are, because I think one of the biggest fears that women have is suffering from breast cancer. It's I think, again, culturally ingrained in every culture. A woman would worry about breast cancer, though we now know that the cardiovascular risk is the highest risk factor women have, and that is why they do end up dying. But tell us about, the survival rates and the breast cancer numbers.
Yeah, absolutely. So what we know, there's about 60,000 new cases of breast cancer in the UK per year. That's a big number. Big number. And we're thinking that over the next 10 to 15 years, this is going to go up to 70,000.
Wow.
So it's just going up and up and up. It used to be kind of 1 in 10 women would develop breast cancer, or then 1 in 8. It's now gone to 1 in 7. So it is becoming more common, sadly. There are about 11,000 deaths a year from breast cancer. But it's not that will be the 60,000 people that are diagnosed. It's going to be the people that are living with breast cancer. So the overall survival rate is good. So back in 2018, they looked at the figures, and the 10-year survival is 80% overall for breast cancer.
Okay.
So that means if someone's diagnosed with breast cancer, the chance of them being alive at 10 years is 80%. Okay. But we know that if you have cancers that are caught earlier, so for example, we talk about like early stage cancer, small tumours, not involving any other area, we're looking at high 90s. So 5-year survival of high 90s. And a lot of these improvements are due to picking things up earlier, and also the other treatments that we give. So I'm a surgeon, so we talk about surgery, but there are lots of other treatments that are available, and they all improve the overall survival from breast cancer.
Okay, and if we talk about treatment options, what sort of treatment options do patients have if they are suffering from breast cancer?
Well, most of the time patients will need an operation. That will form part of the treatment.
Okay.
So I'd say the vast majority of patients will need an operation if they're fit enough for an operation.
To remove the lump or the
Exactly. Now, each patient, when they're seen in our clinic, they will be discussed in our team meeting if they've had a biopsy, and we will make a plan from there. There's lots of different types of breast cancer. There's lots of different grades of breast cancer, so how aggressive things are growing. And we will make a personalised treatment plan for each patient. So as I say, surgery forms part of the treatment in the vast majority of patients. There's also radiotherapy, that's the X-ray treatment. There's tablet treatment, so that's to reduce the estrogen in the body, because the majority of cancers are fueled by estrogen, men and women. And then chemotherapy is also an option. That's the thing that probably scares people the most. And these treatments are to reduce the chance of things coming back. So be that the X-ray treatment, the radiotherapy, be that the chemotherapy. We've also got treatments like anti-HER2 treatments. And then there's more advanced treatments now that are coming through. I won't labour with the different names and things like that, but we've got more and more advanced treatments. And year on year, we're getting more and more treatments for patients to improve their overall survival and reduce the chance of things coming back. So it can be quite complex. And it can be quite a journey for patients. But that's why we have our breast care nurses to support, lots of literature, and just try and take it in a stepwise manner, really. But there is lots out there now. I think breast cancer is probably one of the most researched cancers worldwide, actually, which is fantastic for the huge number of patients that develop it. But there is a lot out there now.
Yeah, that sounds really promising.
Absolutely.
So I guess, seeking help at an early stage is key.
Absolutely.
As you know, sometimes for patients, very daunting, especially, if they're on a 2-week wait pathway, the GP has referred them for a potential breast cancer, and they're really scared. They don't know what to expect. So tell us how your clinic looks like. What should a patient expect once they are coming to see you?
So in our unit, patients will come into the reception. They will hopefully know that they've got an appointment. They know they might be there for a couple of hours to make sure they get the parking sorted, because that can be anxiety inducing. And they'll usually have to fill out a questionnaire. So that's just a little bit about them. So they can tell us about what problem they've got, how long they've had it, if they've had mammograms in the past, so we can then pull those and compare them if we need to. History about their periods, when they started their periods, when their last one was, if they've had children, if they're breastfed, all of this sort of thing. We will then bring them into the clinic room. They'll be seen by a clinician. Sometimes that's a breast surgeon. Sometimes that can be a breast care nurse who are trained in doing the clinics. And then we'll have a chat with them. So we'll go through what their problems are. We'll go through their past history. And then we'll move on to examine them. So when we examine them, we'll examine both the breasts and we'll examine both the armpits as well. Also, if there's any other issues, we'll have a little look at that. If we've examined an area that we want imaged, then we usually mark on the patient the area of concern, and then we send them round the corner to the imaging department. So patients will either have ultrasound scan and mammogram. Sometimes they'll have both, depending on their age. So we don't do mammograms in women under the age of 40 because mammograms are not very helpful in that age group. If there's a lump, for example, then the patients will have an ultrasound scan, and if they're over 40, they'll have mammograms as well. If we see something that we think we need to sample, then they'll have a little needle test and have that area sampled there and then. They'll be talked through that. They'll give them some local anaesthetic if needs be. Patients generally tolerate it quite well. And there's always somebody there to hold your hand in each of these things. So if you are a bit worried or a bit scared, or you want someone to come and sit with you and join you, absolutely fine. After the procedure's done, the patients then go home and we'll arrange for them to come back once we get the results of that biopsy. So typically that can take, as I say, up to a couple of hours. But one thing I would say is 95% of the people that come to our clinic are reassured and discharged the same day. They don't need anything further. Everything is found to be okay.
That sounds very good. So if you're listening to this and, you're worried, you need to speak to your GP, and seeing a breast surgeon is not that bad. I mean, it's a whole process, of course. And of course, you're going to feel a little bit anxious about the whole process. But hopefully the chances of it being okay are quite high.
Absolutely.
So, Salena, in the end, is there any sort of message you want to give our viewers with regards to their breast health?
Absolutely. So it's really important to know your breasts. That is the top message, I would say. Some people know they're a little bit lumpy bumpy. Know your lumps and bumps. Make sure you check yourself once a month, usually after your period if you're having periods, and make sure that you check all areas that are important, so the breasts and the armpits as well. I know it's difficult to know how to examine yourself properly. There are lots of websites that are available. So there's lots of resources. So Copperfield, they're a charity and you can register with them and they will send you text messages every month to say, now it's time to check your breasts. Because often time runs away with us. Before we know it, October's come to the end. I still feel like I'm in, I don't know, June. So that will then remind you, make sure you check yourself. Breast Cancer Now have lots of resources. Cancer Research UK, all of these places will give you tips on how to examine yourself, what to look out for, when to seek advice, and what you can do to help yourself as well. So knowing your breasts is the key thing. And if you know something is not quite right or something looks a bit different, make sure you go and speak to somebody. Be that your GP, be that you go and see somebody privately. It doesn't matter, but just make sure you go and see somebody.
Thank you so much, Salena. So if you have any questions that you want Ms. Bains to answer, you're more than welcome to direct message us, email us. We're going to put a link down below for you to use. We hope you enjoyed this episode of House of Health Podcasts. See you soon. Bye.